Hello everyone, my name is Ahmed Abdul Wahab. I'm a postdoc fellow at MUFC South Carolina. I'm also a former clinical fellow at Hydrocephalus, where I completed my neurosurgery residency. So during my second year of residency, I had a 43-year-old male patient presented with increased ICP, right side weakness, disturbed conscious level of Glasgow Coma score of 11. Patient, as you can see here, CT had a left basal ganglionic intracerebral hematoma with intraventricular extension and hydrocephalic changes. The standard care at the time were EVD insertion, and we did that post-operative. The patient had an MRS of 3. However, post-operatively, the patient suffered from pneumocephalus, meningitis, and encephalitis, and after 63 days, the patient was admitted for EVD revision, and after that, the patient expired. So this patient inspired us to dig up into the literature to see how can we do that differently. So by digging up in that, we found ventricosubgaleal shunt. It was first introduced by Dr. Von Mikulicz, and initially it was used for hydrocephalus in pediatric patients as a simple and rapid CSF decompression method without any electrolyte and nutritional loss. So we conducted a study of 30 patients prospectively, including intraventricular hemorrhage, subarachnoid hemorrhage, and cerebellar hemorrhage over the course of a year. Under general anesthesia and supine decubitus position, we chose a black Newton catheter to be used as a manufacturer for ventricosubgaleal shunt. An advantage of its tip because of its blunt tip that allows insertion of a brain stylet without slippage. And the first step was to prepare the shunt. So basically, we marked with a silk suture the proximal 5 to 6 centimeters, and then I did a curvilinear incision. And we created a generous subgaleal pouch to act for volume taking, and we irrigated that pouch to check for hemostasis. And we used the cohort bear hole as a standard bear hole for EVD, and we anchored the shunt with a 2.0 suture to the periosteum. After that, we did closure and follow up the patient with a post-operative CT to ensure that the tip of the catheter is at its place and no other complication in terms of intracerebral hematoma or misplacement of the shunt. And we assessed our patients in terms of VB shunt requirement, MRS, number of procedures requirement to resolution of hydrocephalus, and also the presence of any complication or mortality, and the degree of conscious level in terms of GCS. To find that statistically significant on follow-up, there was a difference in terms of conscious level, and also about 80% no complication in terms of infection, and 16% had only obstruction of shunt, and 3% with pneumocephalus, and more than 80% of the cases survived. And that thanks to the advantage of the rich blood vessels and the lymphatic channels in the subgaleal bucket that we created to act as a physiologic bridge for up to 3 months without the need of any pocket tapping. We were not the first who addressed that advantage of ventricosubgaleal shunt. Actually, Nagital in 2012 did that, but he used that in the neonatal period population for both hemorrhagic and post-infectious hydrocephalus. Also, Ni et al. Did evaluate the efficacy of ventricosubgaleal shunt in comparative to EVD, but he used GCS, not MRS. And also, El Fadli et al. In 2022 did compare that, but he included only patients with a spontaneous intraventricular hemorrhage. So our study was not perfect. It was a single center study, and the long-term follow-up is lacking in that data. So further investigations are required for that regard. In conclusion, VSG provide a temporary minimally invasive alternative with fewer complications in terms of infection related to in comparison to EVD, and despite its widespread use in pediatric cases, but it is underexplored in the adult cases. Thank you.